going to start with Cameron, and we're going to do one with me, and then I'm going to just start putting up numbers and telling you, patient's in shock, this is what I see, what does it mean? Okay? And you got to know the answers. This is real. Okay? Cameron, you're on.
Okay, so this is so cool. I'm going to use this. All right, we're going to go through a case. This is a real case. This happened 2 weeks ago. So we're just going to run through it, and then there's parts at all of this where I'm going to ask you questions. Okay, so 43-year-old male, no prior past medical history. He's playing racquetball. He gets nauseated. He excuses himself, goes into the locker room. After 5 minutes, his partner is wondering why is he still in the locker room. Goes to find him, finds him unresponsive and apneic on the floor. So he calls 911, starts CPR, and a bystander comes in with an AED, and at that point a shock's advised. So he gets a shock, and they continue CPR because he doesn't come back yet. And ultimately, when the EMS gets there, he's in asystole. They place a couple of IVs, give him epinephrine, give him vasopressin, continue to do compressions. After about 20 minutes, they finally get a return of spontaneous circulation. Okay, so this is actually while they're in the truck rolling to Presby. So they get to Presby, and at that point, he's comatose and unresponsive, and they're doing bag mask ventilations. His heart rate is 124. His blood pressure is 97/56. His SATs are 92%. He's intubated without meds right there in the ER. Okay, and right after intubation, his heart rate is 144. It's sinus. His blood pressure is 72/44. What do you do? So what's your assessment right now after intubation? How's he doing? Okay, hypotensive, tachycardic, and what do you characterize that? Why is he in shock? What's your guess? What happened? Could be, but what changed from? So you went from this, right? See, it didn't work. Darn it! I'm trying to get off the AC. It's not working.
If you touch it, then it'll think you're changing. No, as long as you touch the thing, it'll think you're clicking on the mouse.
Oh, it will?
You can't draw on it.
I can't draw on it? Shoot.
I guess not.
I thought, Jim, we just drew on it a second ago.
No, but you were in the finder. You weren't in the actual
Oh, I see. That's too bad. I want to be able to draw it.
I'm going to draw too, so.
Yeah, that's okay. We'll
I
look
like
at
playing with toys.
Sorry about that.
Yeah,
I thought that,
so do I. That's okay. You know what we could do? We could do this.
Yeah, that's
Yeah, okay. So we'll do it here. Okay. This is big enough. You guys can see. Okay, so we went from here to here, right? So what changed?
Probably auto beep over.
Okay, so forget about even auto beeping, just underfilling, right? Because what's the effect of intubating? What do you do here? Positive pressure, right? Exactly. So you go from negative pressure to positive
So what
pressure.
I taught you was actually true.
Okay. So instantly you cut preload, right? So what do you do? What's your response to this?
Give you volume.
Volume, right? So at this point you need to be bolusing, and you got a couple 18 gauges, so you bolus. Okay. So now here's the presenting ECG. Oh, gotta erase this. All right. Here's a presenting ECG.
Oh wow, you did that.
Yeah, isn't that cool? What do you guys think of this ECG?
But you have to stay in this mode. You can't be in.
Yeah, you can't be in the full screen, but it's pretty big. You can see this. Peak
See
T
around
wave.
this thing or not?
What's that? Systemia, right? What's this? Whoa, right? They call these tombstones, right? Not quite full tombstones. These are modest tombstones, right? What kind of MI is he at? Anterior wall, right? So this is a big anterior wall MI, okay?
Left main stem.
So the patient's found to have 100% proximal LAD when he goes to the cath lab, and they perform PCI, place a stent. They do an LV gram, and it's 45% with 2+ MR. So interpret this for me. What does 45% with 2+ MR mean to you? Is he doing well, poorly? What's that mean? Why poorly? 45% is not that bad. 55 is normal, right? Okay, exactly. So this is an important piece.
Stop. You keep going. That was excellent, but keep going with what you're saying. What does that mean, retrograde? That I understand that it's not going forward, but it also means that since it's retrograde, that in the lower pressure
increases right-sided pressure.
That's true, but it's also retrograde. So in actual fact, his actual ejection pressure is much lower than his arterial pressure. So he's actually reduced. So chances are, if he didn't have any tricuspid urge at all, his ejection pressure would be much lower still, right? Yes.
Okay.
Do you
So
agree with that?
this is an important point. I mean, in this case, it was an LV gram. but I want you guys to grasp this for echoes in particular, right? And particularly when you're dealing with somebody with heart disease, right? Which is that if they have ischemic MR, or MR for any reason, doesn't have to be ischemic just because they're old, right? And they've got MR, then whatever EF you're seeing is a gross overestimate of their cardiac output. Because essentially what you want to know what cardiac output is, right? And this doesn't really tell you, right? It tells you that his cardiac output is poor, but you don't know how poor, and it's clearly an overestimate, okay? So if he had 0 MR, it might be 25%, right? Now, the arterial sheath is left in place and the patient is transported to the CCU. What monitoring do you want, both in terms of invasive and non-invasive? What would you guys like? Beyond the standard. I mean, he's obviously going to get an ECG and a pulse ox.
He's got an art line.
He's got an art
So
line.
you can get a cardiac output and cardiac.
So what monitor?
How are you going to do that?
Yeah, fine. What do you want to tell him? What do you want to put in? What do you want or not?
Well, if we have the A line, you can put the VGLAO on.
Okay. So that's one option, right? So explain to me how does that work?
Thermal dilution.
What?
Thermodilution? No, not thermodilution.
Pulse pressure.
What's that?
Pulse pressure.
Okay, pulse pressure. So
He's got that like.
how does pulse pressure turn into cardiac output?
The variation.
Okay, so how does variation turn into cardiac output? Doesn't actually. Well, no.
Areas
Pulse
are
pressure
curved.
variation doesn't actually turn into cardiac output, right?
At all.
So what?
That's volume responsiveness. The pulse pressure is determined by the stroke volume and by an algorithm that looks at the pulse pressure, knowing the height and the weight and the age of the person, you estimate the cardiac output on a beat-to-beat basis using the VGLAO.
So you use the waveform, and you do take kind of an area under the curve, so you're doing an integral essentially of the waveform, right? But it's not the variability of it, it's each waveform. That's important because if someone has atrial fibrillation, okay, is their pulse pressure variability valid at all? No. Is their cardiac output valid at all? Perhaps, right? Because some of their beats are normal beats, right? And have something. Okay, so you have to know what info you can use and what info you can't use. Sorry. Okay.
A whole bunch screaming at once. Look at that. Go on the other side. You can see better.
So what else? What else do we have here? So for you guys who just came in, this is a patient who's 43, collapsed with a STEMI, cardiac arrest, got 20 minutes of CPR, just got Ross, comes to the ICU, got actually in the ER, got intubated, got hypotensive, got some volume, now is still coming out of the cath lab. Okay, they just stented him. They shot this LV-gram, 45% EF with 2+ MR, and now we're talking about the monitor you want. So one option is to throw in something like a VGLAO, right? That's going to give you non-invasive, cardiac output and pulse pressure variation. What else? What are your other options? What else could you do here? I mean, does everyone agree we want to kind of monitor cardiac output? Is that pretty much agreed upon, right? Because this is somebody with low cardiac output.
What happened post-CAT?
Well, we're going to get to that, right? But
We're
you already know.
You're standing here. It's your patient. What are you going to do right now?
I mean, this patient had a cardiac arrest, has right now this LV-gram, right? So your suspicion of his going on to have cardiogenic shock is very high, right? So he's at risk for it. So you want something to know that, right? So what are your other options?
I was just thinking, before we move on past the A-line integral under the curve thing, how does that account for changes in the systemic vascular resistance? Like, what do you actually do to account for?
Well, that's a very good question.
Yeah, it's a very good question.
But with mitral regurgitation, the forward flow is still going to cause the pulse. And that will still be a calculation of the stroke volume. So if anything, it'll still be accurate, assuming, of course, that you have a waveform that you can interpret. In really bad cardiogenic shock, the waveform can be so depressed that the device can't even calculate it. And the pulse pressure is less than about 15 millimeters of mercury. That son of a gun VGLAO turns off and won't even report to you a number, even though it can calculate it.
So the tone is not as big an issue as you would think, and I'll show you why. Here, we're gonna use our.
You're not in the clicky mode.
Yeah, how do I do it? Hold on. There's a.
Probably forward
Oh, here, I can do this. Go down here. This is the old-fashioned way. Okay, so this is the reason why. Let's say that I'm going to draw two simple peaks. There's a peak, okay, and there's a peak, okay. This is vasodilated, let's say. This is vasoconstricted, right? Narrow pulse pressure, wide pulse pressure. What's the area under the curve of these two
So it
peaks?
tends to stay correlated?
So you do get a little bit of a change in the area under the curve, but not a lot.
The
Okay,
major
so it's
determinant of the
pretty
area of the
close.
curve is going to be the flow. So stroke volume is going to be the major determinant of that.
Okay, so these two end up having the same area under the curve. It's just one is more widespread, so to speak, and one is higher peak but more narrow. Okay. I love this toy, man. God, this is great. Okay, let's go back to. All right, so back to the hemodynamics. So, okay, so other things you'd want monitoring. What else can we use here?
Central line for CVP.
Okay.
And a CCO swan.
So you could get a CVP, you could get a swan in, so you can put a PA catheter. What else can you do with the central line? So what's a CVP good for, by the way?
Just to monitor trends and volume status.
What?
To monitor preload.
What does it tell you about preload?
You didn't come to my lecture
Coast- Coast call.
It just gives you a snapshot of where you are in terms of your volume, but it doesn't tell you where you are on the Frank-Starling curve. So you can, I guess, follow trends within the same person and use that.
Okay, so let's talk about the training for a second. So let's take this patient, and let's say that I enrolled him in a trial, and in my trial, I am going to restrict his volume so he gets no additional volume except for when he pees out. So he stays absolutely euvolytic. I do not change his intravascular status. And now I'm going to occlude his LAD so his function worsens. What's going to happen to his CVP?
It's gonna go up.
It's going to go up. Did I bolus him?
No.
So how does that trend help you? If his CVP goes up over time, does it mean he's now intravascularly full or his myocardium sucks?
No, really, you can't use that number as anything.
So in the setting of a failing heart, trending the CVP is useless.
Useless.
Right.
Stop looking at
The
it.
CVP tells you the heart sucks, basically, because you can't have a high CVP in the absence
Remember
of disease.
the fourth rule,
Right.
Pinsky rule, an elevated CVP.
Oh yeah, that's right.
CVP is only
Yeah.
elevated
Yeah.
in disease. It's only elevated
I
in
forgot
disease.
about your rule.
That's the rule.
Yeah.
That's what he just said. The heart sucks, the CVP is only elevated in disease. It's the
But
same.
you could use a swan to get SVO2s, like true mixed venous.
Sure. That's a different thing, right? Okay. So you mentioned CCO swan, right? Which a CCO swan uses what?
Continuous thermodynamics.
Not continuous thermodilution. It's not.
Intermittent bolus.
Yeah,
It does-
intermittent boluses,
it does
and
it like that.
then some of them also have the little laser Doppler piece at the end, right? You can get what else out of the PA catheter? You're saying SVO2, right? So SVO2 correlates to cardiac output how?
Well, it's a measure of global perfusion, right?
Okay, but what's the equation that governs that?
You want the actual, how do you?
No, you don't have to give me all the variables. What's the name of the equation that correlates? Fick equation, okay? And what are the other components of the Fick equation? You just need to know what's in there.
SaO2 minus your O2 consumption, which is VO2 divided by hemoglobin, cardiac output,
Good.
and then some
Perfect.
fixed.
Perfect. So I don't care if you know the constants, but the point is you got to be aware of if the patient becomes more anemic, their SVO2 changes, right? If their arterial sat drops, so this guy was 92% sat, I think I said on the last slide, right? That's going to lower his SVO2, right? So if his SVO2 is 68, that might be a completely normal extraction, normal cardiac output, right? So you have to just know those things that are there,
Now,
okay?
you remember the algorithm I gave you at the very end of the lecture yesterday, in which I said you start with the SVO2 if it's low. These are the things that can cause it, and that's why you would treat them. And one of them was if you're anemic and your cardiac output is high and your arterial O2 sat is high, then what you need is you have decreased oxygen carrying capacity. You need hemoglobin. But if it's low and you don't, and your cardiac output's normal, or if your cardiac output is low, then that's just impaired consumption, and you need increased cardiac output. But it's always going to be dependent also on myocardial oxygen demand. Heart's oxygen, the body's demand. So this person's totally zonked, so he's not exercising. So his metabolic demand is not going to be very high, and hopefully they're cooling his brain at the same time because he didn't wake up after the code. So he's going to be slightly hypothermic, though I don't know that to be the case because he hasn't told me.
Yeah, I will tell you. I think the next slide's going to tell you.
But the point is, so you can use that as a measure of the relative effectiveness of cardiac output. And the problem with the mitral regurg is the heart can be beating all you want. You don't know how much that's going in the right direction. So one of the nice things about SVO2 is it tells you functionally that I'm winning or losing the battle of perfusing the body.
So at that point, so if I do thermodilution with MR, or TR would be more essentially, right? What's the effect?
Can give you a broader, wider.
Yeah, and it's going to throw it off, right? Whereas SCVO2 or SVO2 doesn't get thrown off. So how does SCVO2 you know what I mean, central venous O2 coming out of, say, a subclavian or IJ, how does that correlate with SVO2?
Or 10 off. Or 5 to 10 off.
Okay, is it useful? Is trending the SCVO2 useful? Yeah,
I think so.
okay. So
If
that's
it's
something
low,
you can track,
it's good.
right?
It helps you. If it's high or normal, you have no idea what it means.
Okay, but still, it's a helpful thing. So these are all your options in terms of invasive, non-invasive, right? And there's not a right answer. There's just, you got to have a plan, right? Okay, let me get this. Okay, so the patient has a subclavian triple lumen inserted. The venous gas is 722, PCO2 is 42, PO2 is 35, SAT is 52. What do you think of that? So that's a low SCVO2, right? SAT's 52%. So this guy's got some degree of low cardiac output, right? Arterial sheath's connected to a pulse waveform non-invasive cardiac output device. That's because I don't use trade names, right? That some would call that a visual AO, right? And so the estimated cardiac output is 3.1 liters per minute. The index is 1.6. The stroke volume is 42. Okay. The CVP is 14. We kind of already talked about that. Doesn't matter, right? So obviously, he's in a low cardiac output state, okay? The patient's heart rate is sinus at 132, blood pressure is 92/55, his MAP's 62. Here's your vent settings, so you got a rate of 16, tidal volume 600. Because he was hypoxic, he was on a PEPA 10, and his FiO2 is 1. And then his ABG shows you 727, PCO2 of 38, PO2 of 66, his SAT is 91%. He's not overbreathing, okay? What is your overall assessment of his hemodynamic state?
And why? Why don't you abuse them by pointing to specific people and asking them a question? So their level
I don't know
of-
everybody's names.
So their level of
It's good you guys
anxiety,
code up.
their level of anxiety will rise more knowing that they're going to have to answer.
So-
Because, you know, my guess is that you're all doctors and that you also take care of critically ill people. Now, that's just a guess on my part, but therefore you really are going to be at the bedside doing this. So why don't you try to answer it now?
By the way, this just so you know, just because I love this, that I can draw. Wait, what happened?
You're on the
No, that's
erase.
the erase.
You're erased.
Oh, I'm on erase mode. I gotta put this back. Okay, here we go. Yeah, there we go. Okay,
Oh,
So-
wow.
this is the anxiety learning curve, right? So, no anxiety, no learning. Too much anxiety, no learning, right? We're trying to get you guys right there, okay? So, we go back. All right, so first let's talk about, make that go away. Let's talk about the fact that, why did I tell you he's not overbreathing the ventilator? What's the reason for you knowing that? Sean?
Consciousness, or was pH is 7.27, so
Well, he doesn't want to. This is not something his body is actually physiologically trying to do.
Okay, so he's not overbreathing. How does that help you? What does that help you with? If the patient is hooked up to a visual AO, like we talked about, Frank, what does the fact that he's not overbreathing do for you?
If he's synchronized with the ventilator and the ventilator is giving him every one of his breaths, what new information can you now use to manage his patient?
Stroke volume variation.
Okay,
Oh,
stroke
yeah.
volume variation, right? So stroke volume variation is thrown off by him forcefully breathing, right? Taking in big breaths or
Spontaneous breathing,
radical
you can't use
breathing.
it.
Right. So this is a useful thing because it means your assessment now can not only be of his cardiac output because it spits out that number for you, but now you can take SVV and you can use that to do something useful.
Yes, what's your question?
If you have I apologize, I wasn't there yesterday, so you might have answered this, but if you have a high stroke volume variation in a spontaneously breathing person,
Doesn't mean anything.
it still doesn't mean anything.
No.
What's your stroke volume variation right now? Sitting at about 25%. Okay.
But the problem is if you're breathing spontaneously, with spontaneous inspiration, you're going to increase venous return, right? And if I increase venous return, I'm going to make the right ventricle bigger, and that makes the left ventricle stiffer by ventricular dependence, and therefore the left ventricular end-diastolic volume will be changing. But what is preload? Preload is an end-diastolic volume, it's wall stretch. And so since you've changed the compliance, the wall stretch hasn't changed, but the volume is less. And so you're going to see a different stroke volume variation during spontaneous breathing because of changes in compliance that have nothing to do with contractility. It has nothing to do with volume responsiveness. So pulse pressure or stroke volume variation in spontaneous breathing, it just means you're breathing. It has to be during a positive pressure breath that you don't see the increase in volume decreasing compliance that allows you to use stroke volume and pulse pressure variation.
If it's low in spontaneous breathing, does that give me any
Nope.
information there?
Doesn't help you.
No extreme. There's no extreme that's extreme enough.
You could do a straight leg raise.
Passive leg raise.
Leg raise.
What if
You can actually have the legs bent too as you raise them too, but that's okay.
What if you're over breathing, but it's still the vent, it's a volume controlled breath?
Depends what happens to total pressure, and it's hard to tell.
It just depends how. So if you're barely taking a breath and just triggering, right, it's probably still valid, right? But if you're forcefully breathing, and certainly if you're pulling off the demand valve, so you see the exhale tidal volumes are in excess of the dialed in, then it's worthless, right? So it kind of depends. It's like Michael said, it's the pressure, right? And you don't know for sure what
How
the
much
lower
they're
pressure is.
contributing to
Yeah.
it.
Okay, so what do you think this patient's having right now? What, doctor? What's going on here? Well, you have tachycardia. What's my first rule?
It's always pathologic.
Yeah, pathologic. Tachycardia is never a good thing. But the mean arterial pressure is 62. Remember my lecture on blood flow distribution? 60 or so in a person should be okay. The stent's in, so we have enough pressure for perfusing theoretically the heart, but you don't know about the brain because you don't know what the intracranial pressure is, so you don't know perfusion pressure. But your blood pressure is at a range that you at least think it's that you should be perfusing the organs, okay? But my cardiac index is quite low, and if I look at my arterial blood gases, what do you see? With a pH of 7.21 and a PCO2 of 38, what is that?
Metabolic acidosis, right? So this guy's in shock.
Circulatory shock. Okay.
Okay. So what are you going to address first in fixing the shock?
Well, only a couple of things you can do. Oxygen content, cardiac output, and blood pressure, right? There's something else I'd like to know. Okay.
So what do you want to fix first?
Sad.
Okay, why cardiac output? Why wouldn't you give him
I
a
think
pressor
that's
right
gonna-
now?
Well, I think it's going to drive everything. So I don't think you have enough fluid flow to meet the tissue and metabolic needs.
Okay. Good. And what's the downside if you start him on a pressor? What happens? Anemia?
You increase that.
Okay.
Sorry.
Good. No, that's okay. That's exactly what it is. You increase afterload, right? So if you
Even though you weren't the one who was asking. So
yes. All right. So let's flip over to this. So this is what his waveform looks like. Okay. And what am I showing you here? First of all.
Ventilator pressure curves.
Okay, so this is the airway pressures, and here's the art line, okay? And what are you observing here?
There's a stroke line. It was volume variation.
So, well, you're observing a pulse pressure variation, right? But then the machine from that will calculate for you a stroke volume
But the
variation.
pulse pressure variation is just as accurate. So
Yeah.
that's what you said.
It's the same thing, right? Because this part, which they're highlighting, you can see they have it labeled as SV max and SV min. It is, in essence, just the pulse pressure, right, being calculated from
The area under the curve.
the area in the curve being calculated from the A line. Okay, so what number here would be indicative? What amount of stroke volume variation would be indicative of someone who's preload responsive? Okay, 13%. So higher than 13 or lower than 13? Higher than 13. So if they're higher than 13%, the right thing to do for this guy in low cardiac output is give him a bolus, right? If he's lower than 13, then you have other options, right? So he gets two 500 ml boluses, and the result is cardiac index goes from 1.6 to 2.1. You start him on maintenance fluid. The SCVO2 is 58%. The stroke volume variation now is 7%. The lactate's 4.2. Here's your vitals. You have a heart rate of 108, blood pressure 92 or 51, the MAP 61. What's your next treatment? So how is he doing at this point? Is his cardiac output good, horrible, bad?
So I think it's improved.
Better
I mean, it seems volume is, well, I think you did all you can with volume, it seems like, because the stroke volume variation is now gone.
Okay, so you improved his cardiac index, right? Is he good? Are you happy with that cardiac index right now? Okay, is he out of shock?
The lactate is 1.2.
Well, does he have a normal cardiac output?
We don't
No
know.
such thing.
There's no such
There you
thing.
go.
There you go. Very good. So is his cardiac,
Dr. Pinsky, we've been listening.
is his cardiac output good enough for him?
No,
Not
that's
yet.
the
And what tells you that?
lactate.
Still got a lactic acidosis, right? So
There's
it's
no such thing as a
inadequate.
normal cardiac output. The question is, do you need to have it go up or can it stay there? And for that, knowing the cardiac output value doesn't tell you. It's everything else that tells you. But then you measure it to see that your treatment made it change. So you need to measure cardiac output, but it's not because that's the endpoint. That's the result of the treatment.
Okay, so Elena, what am I going to do now? Stroke volume variation is 7%. Cardiac output's not optimal. What do I want?
So at this point, like we said, we've already exhausted our fluid opportunities, so we have to move to improving the pump function. Iron.
Okay, what ion sugar do you get?
Yeah.
Dobutamine? Okay, what's that going to do to blood pressure?
I could actually drop it.
Okay.
It might.
It could. It doesn't always, right? Because the beta 1s are so-so, right, on vasodilating, right? What are your other options? What else is on the table?
Still tachycardia, but we wouldn't do anything that really increases heart rate. So,
No? You wouldn't? Why not?
Give him a little epi.
He's 43. You reperfuse him, right? You open this clogged artery, right?
There are three.
when in doubt, give epi. So.
Okay, well, not always.
Not always.
But epi in this case is not a bad choice, right? Because it's not going to drop the pressure, and it will probably take up the heart rate a little, but that's okay. You can handle it.
But in
Okay.
there, but in all fairness, though, when Daniel DeBacker had his paper in the New England Journal looking at the various drugs, they found that epinephrine wasn't as good as norepinephrine and dobutamine in the management of shock. So, and the reason, that it made the lactic acid a little higher, who cares? That's just increasing metabolism per se. But there's nothing wrong with epi in a healthy, otherwise healthy person because they can handle it. The advantage of epinephrine is it'll vasoconstrict the periphery, increase your venous return if you need that. Okay, it can also cause more tachycardia, but there's nothing wrong with epi. If your back's to the wall, God pulls out epi.
Exactly.
Okay, so
That's how you were wired. So, moving on to the next thing. So, all right. So after the initial shot, so the patient started epinephrine at 0.1 mics per kilo per minute. So at 0.1 mics per kilo per minute, I'm sorry, I don't know your name.
Chapin.
What is it?
Chapin.
Chapin. So at 0.1 mics per kilo per minute, is epinephrine an inotrope, a vasopressor, or both?
Actually, don't know the answer to that.
Okay.
I think it's a
Anyone?
moderate
I would
dose,
think
so it should be
it's
both.
Higher.
Is it both?
Well, higher doses it acts as a.
What's higher?
So
Define higher.
that's what's actually, I asked Bob Clark, he says 0.15, but
Okay.
you might say 0.1.
That's close.
I don't know.
Well, I'm not just going to make it up, right? So there's lots of
I didn't
animal
know.
studies,
Actually,
and there's a
people-
beautiful
people
study in the
say higher
European
doses.
Journal of Clinical Investigation in like 1960 that actually did this in a bunch of normal volunteers, and then there's a bunch of studies in the 70s where the Americans did it too, okay? Infusing epi into patients, right? And somewhere around 0.2, 0.25 that you go from vasodilation to vasoconstriction, right? So up until that point, you're mostly an inodilator, actually, a little bit, okay? Because your peripheral beta, your beta on your heart and your beta peripherally is acting primarily, not so much alpha, and then your alpha starts to kick in, okay? So this is kind of an inotrope dose of epi, okay? It's going to drive the heart. It may dilate the patient a little bit, not a ton, but, you know, it depends on kind of what else is going on, okay? Hypothermia is initiated after the return from the cath lab, and his temperature is 34C. What is that going to do to the SVO2 right now? What's your name?
Manasi.
What is it?
Manasi.
Manasi. What's that going to do to the SVO2? Hypothermia.
Your metabolism is going to decrease, so your SVO2 should come up.
Should come up. Okay.
assuming
It's
everything
curiously-
else remains the same.
Okay.
Yes.
Yeah. All of these questions, I'm kind of assuming that, right? And then, what's that going to do to the patient's heart rate, function?
Should drop the rate.
Okay. It's going to drop the heart rate. Is that going to drop cardiac output?
Should not.
Why not?
Let me think what happens to the output.
What
Your
determines
goals are
cardiac
going to
output?
be preload, upload, contractility.
So you're not changing venous return. So as long as the stroke volume can increase, changes in heart rate should have no effect on cardiac output.
So that's the key. The stroke volume increase, right?
Stroke volume.
Because cardiac output is stroke volume times
Into heart rate.
heart rate.
And if cardiac output's fixed, and you just double your heart rate, you'll cut your stroke volume in half. So that you can't. The heart rate's a very poor way of changing cardiac output.
Do you vasoconstrict the?
Yeah, that's what I wanted to know. Do you, when you're cold, you will constrict?
Well, not centrally. No, actually, I was going to say that you really do not at 34 cause significant vasoconstriction, but you significantly increase viscosity. So if you have, you will see an increase in pressure simply because the blood is thicker in the periphery. So one of the nice things about hypothermia is that they have a nicer blood pressure. One of the bad things about warming them up is their blood pressure falls.
Okay. So now after an hour, here's the current state. So we have a heart rate of 92, blood pressure is 102/48, the MAP is 62, the SVV is 6%, the cardiac index is 3.2, the SCVO2 is 72%, okay? ABG is 7.31 and the lactate remains 3.5. Is this patient in shock? Yeah, okay. Their lactate's still high, okay? What form of shock is he in? Yes?
You actually brought up a question I was wondering about a little bit earlier. Is it, you know, we started something epi now, you know, that semi-falsely elevated the lactate, maybe falsely is the wrong word, but
But 3.5 is not a level that lactate would go to from epinephrine.
thank
alone.
you. That was
And then beyond that also, I mean, there's a couple things for why epi in this patient shouldn't do it. First of all, it's a low dose of epi. Second of all, it's a younger patient. Third of all, you've got them cooled, so you're kind of combating the increase in metabolism with hypothermia, okay? So really, if his lactate's up, you should think more this is a perfusion problem than I just gave him epi, this is why he's up, okay? So what kind of shock is he in right now? Jonathan, what kind of shock is this?
Well, he has a reasonable cardiac index. He has a low stroke volume variation. He's got still low systemic pressure, so I would be worried that he's vasodilated.
Okay, so how's that pulse pressure, 102/48?
On the wide side.
It's a 43-year-old guy, right?
Yeah, it's not horrible, but it's on the wide side.
Right. So this right now is looking more like a treated cardiogenic shock that now has a distributive component to it, right? And that distributive component could be coming in part from the epinephrine. It could be coming from SIRS, okay, from the cardiac arrest you just went through, okay? But it's a little bit of a mixed shock. It's not pure anymore, okay? So
no
what,
longer pure cardiogenic.
yeah. So what are you going to treat him with?
And the reason that you can say that is because the SCVO2 has come up, and therefore you know that it was low before. So even though it's not a mixed venous O2 set, which we'd really like to have, it's now, the trending though is suggesting that in fact the flow is probably better. So if I'm still getting metabolic acidosis and lactate levels, it means that I'm having a problem with blood flow, and the pulse pressure helps you with that.
Okay. So what are you going to treat him? What's your options now? Taki?
Support them and work him up.
Okay, well, you don't want to warm him up for other reasons, okay?
I want to keep his brain alive. That's
Yeah.
kind of an important
This
thing.
was a VF fat hospital cardiac arrest. What's that?
After 24 hours.
Okay, but you got to do something now.
Yeah, this is 1 hour into it. Or
Okay,
2 hours into it.
sorry.
Right now, what are you doing, doctor? You're the doctor. What are you doing? Nothing? Stay right where you are?
Are you happy with this lactate at 3.5? Okay, so Salmer, you're saying just turn up the epi? Yeah,
That'd be
do
reasonable.
that.
You got it all in the bag already. You don't have to mix anything new.
It's much easier, right? Okay.
One of these
So-
bitches.
So the patient's epi gets increased to 0.25, okay, which now is a vasoconstrictor dose, okay. Temp is now down to 33. Heart rate's 84. So again, the heart rate you've seen come down, right? And this is typical hypothermic effect, but does not change the cardiac output. People worry about this a lot, and you know, at 84, you're not going to really care, but there are going to be plenty of times if you're cooling a post-arrest patient that it's 54, sometimes even 44,
Then
and
it
if their
becomes
blood
right.
pressure is fine, you should just relax. And if it's sinus, okay, because that's typical and it's not a problem, okay. Blood pressure now is 108/68, so the pulse pressure changed quite a bit, right? And the MAP has come up, okay. The index now is 2.9, so it went down a little bit, right? Not surprising because you did take up the afterload. SCVO2 68%. The lactate normalizes about 2 hours later, okay. So we kind of got at this. Why was the heart rate decreasing while the epi is increasing? How do you explain that?
Increase the preload, increase
Well, you didn't change the preload, right?
the
Okay, so part of it is potentially if he was in a vasodilatory state by constricting him, you actually did improve venous return, right? So you took up his systemic pressure, right? His mean systemic, that quantity that's difficult to quantify unless you read his papers, you know, with paralyzing people on the vent.
I don't have to paralyze anymore. We actually just showed you don't need to do that.
You got another way?
Yeah, but that's okay.
All right, so, but there's this mean systemic pressure, right, that is essentially kind of what, if you were to die, where your pressure would level out at, right, versus what your atrial pressure is, and that's what governs the venous return, right? And so by constricting, you take up that mean systemic pressure some, okay? The second thing that happened here we talked about was the hypothermia, right? So he got cooler, so his heart rate slowed down a little. So you actually can, you know, everyone thinks more epi's definitely going to make him tack up more, but you actually can have the opposite effect depending on how vasodilated the patient is.
And there's also baroreceptor receptor, right? If your mean arterial pressure goes up, the baroreceptor slows down the sinus node activation, right? You all agree with that? So you have a lot of reasons that the heart rate, you can use your heart rate to titrate management in terms of seeing that the patient is getting better.
Is the low heart rate a problem for perfusion? No. Okay. And like I said, even in bigger extremes like 54, 44, depending on the situation, it might be fine. Should the patient be afterload reduced, i.e. wean the epi to improve the cardiac function? Are you unhappy with this cardiac index of 2.9? You want to get it up to, 3, 4? Is there a reason to do that? No, right? I mean, because before the patient was in shock, now he's not, okay? So again, don't fixate on the number, right? This patient now overall looks like he's doing fine.
So you're saying the heart rate, I know you keep saying the heart rate doesn't reflect the cardiac output. As you increase the heart rate, you decrease the load and all that. But your body does increase heart rate when it has increased demand. And so if...
And why? Okay, stop.
What?
Why?
Because it needs to
No,
increase cardiac
wrong.
output.
But thanks for playing. Answer it again. Why does it do it? It doesn't. It's because it increases sympathetic tone.
Okay.
And increases in sympathetic tone push several specific buttons, one of which is to increase the sinus node activity of depolarization.
It's a separate...
The second thing,
effect.
yes, the second thing is increases contractility. Third thing increases vasomotor tone, so that you have an increase in mean systemic pressure, increase in heart function, and increase in heart rate together. And that's the normal response to exercise. So the body, think of it like it's a conductor, and then heart rate does this. That because the body's response to increasing cardiac output is to do all of those, all right? But if you just were to give a person volume, their cardiac output will go down. Their cardiac output went up, their heart rate would go down. A healthy person.
But
because
the
it
other
has
thing
sympathetic
about
tone.
the other thing about sympathetics, the other part of your question for exercise response, for example, is what happens to lusitropy during an exercise response? It increases. What is lusitropy? Okay, so in other words, although the heart rate is increasing, which normally would decrease the stroke volume, in an exercising healthy heart, you also increase the stroke volume, so you actually increase
So
cardiac
as a matter of
output.
fact, we once had this big symposium on ventricular function and exercise and disease. And the primary goal of this function was to say to people, stop using exercise physiology to try to explain what happens in critical illness. Because in fact, they're not at all the same. And so that was the point.
Yeah, so you don't get the same increase in lusitropy when you're giving it like this. And the other thing is this patient probably has some disease. I mean, that's how he got a cardiac arrest in the first place. And particularly when you get your older people, they have a lot of diastolic dysfunction, right? So that's where there was a beautiful paper in Circulation a couple years ago that looked at actually pacing hearts at faster rates in people with heart failure with normal ejection fraction, which is code word for diastolic failure, right? Versus normal patients. And what they found is you pace someone with a normal heart and their stroke volume goes up as you pace them faster. But you take diastolic dysfunction, their stroke volume actually comes out and their cardiac output doesn't improve, right? Because they can't dilate. Okay, so that's the important thing.
Okay, I'll go back to your teaching there. I just wanted to load mine up as well, so it's there.
Oh, okay.
So.
Why didn't we increase so his auto stats were like 92%.
Yeah.
In the beginning, I know we had to give him some fluids and we couldn't go up, but later on we could have improved his arterial oxygen stats also to increase your SCTO, right?
By doing what? What would you have
By
done?
going up on the FiO2.
Well, you were on 100%. He was
Or-
PEEP at 10, 100%. Okay, well, if you went up on the PEEP, what would you do to his filling?
decrease. But if he's good volume repleted, then he shouldn't have decreased his spit rate.
As long as that extra volume you give him with the 2+ MR doesn't end up in his lungs, right? So you kind of get into a situation where you might be chasing your tail.
But in fact, one of the things you said is true. As we said in our very first paper with McCard, if you increase PEEP and the pulse pressure variation is very low, you usually don't see the cardiac output fall. So that is correct, but it is a diminishing return. As the lungs get bigger and bigger, you squeeze on the heart and you decrease its diastolic compliance because the lungs are pushing in on it, and it's the same thing as tamponade. So the lower the level of PEEP you can give that maintains adequate oxygenation, the better you'll be cardiovascularly. And since his major problem at the moment is his heart and his circulation, not his lungs, and you don't get much bang for the buck. The difference between a 93% saturation and 100% saturation in terms of oxygen delivery to the tissues is almost not measurable.
So if you really wanted to do something, you use anemic transfusion, right? But he's probably fine, right? What's the effect of PEEP on intracranial pressure? Yeah. So that's the other thing to take in mind. So in all of this, and this summary is kind of, I throw in some things because as a cardiac arrest guy, I want you guys to think about the brain as well as the heart, okay? Which is that with cardiac arrest survivors, first of all, you do get cardiogenic, but also you get a distributive shock. A lot of people forget that there's a distributive component. We already talked about the pulse pressure variability, and the two requirements is you need an intubated patient who's not spontaneously breathing, and he's got to have sinus rhythm, right, to be able to use that. MR overestimates cardiac output. EF by echo and cardiac output often fail to correlate well. Okay, so ejection fraction should not be something you're using reliably. It's not a replacement for cardiac output, right? You can trend it. It can be helpful in some cases, but much more helpful is a PA catheter or visual airway trend or something like that, or SCVO2 that you trend. Elevated CVP merely tells you have myocardial dysfunction. Hypothermic bradycardia rarely lowers the cardiac output. Okay. Widened pulse pressure is consistent with distributive shock, as we saw before, and the blood pressure is the primary determinant of perfusion. And I throw that in there because that's not only true systemically, that's also true in the brain, right? And particularly if your autoregulation is thrown off, that map of 62 may not actually be enough to perfuse this brain, right? You may need a map of 70 or 80. Okay.
All right. Very good.
Okay.
So you're seeing now some real practical applications of the last few lectures we've had. And now I wanted to go on and give you a case. This was a Tales from the Crypt post-op cardiac surgery patient, post-op patient. Okay, this is a study from McGee Women's Hospital. And this is a lady, regrettably, this is a true story. These are all true stories. A 55, I'll read it with you, 55-year-old, 65-kilogram female admitted to the ICU, intubated, sedated, following a transvaginal hysterectomy and bilateral salpingo-oophorectomy for grade 3 uterine CA. That was complicated by intraoperative small bowel perforation. As they were pulling something out, they noticed that it was a small bowel.
I've been called for that before.
What?
I've been called for that before.
And so, and she had intraoperatively AFib, but she's now in normal sinus rhythm. I'm just thinking this would happen. Okay, this is a true story. Her intraoperative fluid requirements were 3,500 of crystalloid, 3 units of packed red cells. She's got a positive medical history for a 55-year pack smoker. She's got a penicillin allergy. She's got peptic ulcer disease, and she's been on an H2 blocker for the last year. Okay. You can't see this. I don't know what to do down here. I can't even read what I said either.
You can drag it down.
I can move this. Okay, there we go. On admission to the expensive scare unit, she was on an 8 ml per kilogram tidal volume. Frequency was 18, 60% FiO2. Her pulse oxat was 94%. She had a blood pressure of 100/50. She was 110 sinus. Her CVP was 18. She had a cool periphery, and her Foley catheter had 500 mLs in it, and nobody knew when it had last been emptied. Okay? So that's, by the way, does this sound familiar? Yes, this sounds very familiar, doesn't it? Okay. So I wanted to go to the next one. How do I let it go? Next. I guess I click on that. Okay. This is what happened. After approximately 15 minutes in the ICU, she became progressively more hypotensive. Heart rate fell to a mean of 55, or I'm sorry, her mean arterial pressure fell to 55. She became tachycardic to 130. Her periphery, which was cool before, was really cool now. She had some JVD. Her CVP was around 15, and since we had an art line in, her pulse pressure variation was 35%. Okay, the most likely hemodynamic condition present in this patient is, number one, acute pulmonary embolus with cardiovascular collapse after all her CVP is high. Okay. And this was an acute event that seems to have occurred over a period of 15 minutes. Ventilation-induced dynamic hyperinflation causing impairment in venous return. After all, she's a 55-year pack smoker, right? So there's potential that could be the case. Progressive hypovolemia following surgery, severe heart failure, or none of the above. What do you think it is?
That's what B.
Okay. Anybody vote for A? B. We got one B. Okay. Ventilation induced. Very, very unlikely. This woman had no symptoms of respiratory problem. Her tidal volume is small and her frequency isn't large. So she's well below any level where dynamic hyperinflation may occur. I give a lecture on dynamic hyperinflation, actually not to our department, but in my Brussels course, and she's well below that concern. But if she did, she would have had a history of severe COPD. She just was a smoker. So this actually is, the answer to this question is that she's actually, it's C, progressive. So you've seen these pictures before. I'm going to show you just again. This was yesterday's slide. There's no relationship between baseline CVT and change in cardiac output. This is just one study by Wagner that was in some journal. I can't remember now which one. And you can see that as the CVP, right atrial pressure, tends to be higher, the probability of the cardiac output going up is less. But for the same increase in cardiac output, you can have a CVP of 2 or 14, or for a CVP of 12, cardiac output can go up or go down. Okay, and our patient was right there. So what we're talking about is using the pulse pressure and stroke volume variation. And the original studies were done by us about 15 years ago looking at pulse pressure variation. Why do I prefer pulse pressure to stroke volume? Because I measure it. I don't measure stroke volume variation unless I put a flow probe on the aorta, which I can do, but it's kind of invasive. The Vigileo, the Lidco, the Picos, they all estimate stroke volume from pulse pressure. So if you have a pulse pressure there, measure it, because it's the primary measurement you're doing. Yes, I agree completely. It's determined by stroke volume. No argument. But the reality is it's measuring pulse pressure first and calculating stroke volume. So if you have a pulse pressure, it should work. And remember, our patient had a pulse pressure variation of 35%. And as you increase, the greater your pulse pressure variation, 35% here, cardiac output's going to go up by 35% if you give them volume. Okay? So the patient received a liter of Ringer's lactated solution, which is my favorite solution. I guess I'm going to turn into a plasmolite person, but there was no plasmolite when I was growing up. We only had Ringer's or normal saline, and I always am a Ringer sort of guy. We slam dunked it over 15 minutes because we understood that this was an acute problem. There was an immediate resolution of the crisis. The mean arterial pressure went up to 70. The pulse pressure variation decreased to 20, which meant the cardiac output went up, because if your pulse pressure goes down as you give fluid, that means that your cardiac output went up, and it goes up proportional to the fall in pulse pressure variation, right? So we felt really good about that. The heart rate decreased to 105 sinus, so she was still tachycardic, and tachycardia is never a good thing, okay? So we repeated the hematocrit an hour later, and post-op, and revealed that it was a decrease from 35 as her last intra-op one to 22. But she'd gotten 2 liters of saline since the last unit of blood, and we'd just given her another liter of Ringer's lactate, so wasn't really sure what was going on. However, platelets were fine, her PTINR was fine, so she wasn't like she was coagulopathic or thrombocytopenic. Her initial urine output, since we decided to clean out the bag, was 15 mLs, okay? So you're the doctor now, and you're at McGee, and the nurse is looking at you. David McGuy's at some conference somewhere, and you've got to take care of this patient. Because of the low hematocrit, coupled with the tachycardia, the surgeons requested that we give her 2 units of packed red blood cells, okay?
being nice people that we are, we obliged. And we gave the 2 units of packed red blood cells over 2 hours. Now, assuming that the patient is otherwise stable, the most reasonable management at this time would be, 1, to observe and follow the hematocrit 2 hours later, to give another bolus of 500 mLs of saline. I didn't tell you she was hyponatremic at this point. Start norepi and titrate to mean arterial pressure over 70, but her mean arterial pressure was 72, so you just have it been. Transfuse 2 units of fresh frozen plasma. Start an infusion of dobutamine at 5 micrograms per kilogram per minute. So, okay. What was wrong with the patient in the last slide?
Tachycardia.
No, that was there, but she had no urine output, right? So unless she was an acute renal failure, and she was never acute renal failure before, or unless they happened to tie off her ureters as part of the abdominal surgery, which Lord knows has happened, which trust me, it's happened. Or more importantly, they sometimes just cut the ureters and they don't realize they have. These things do. The most likely thing is you got low urine output, most likely due to hypoperfusion of her kidneys, yeah.
Do we know the response to the?
Yeah, what
You
happened
gave
when
2
we
units
gave
of
the
blood.
blood?
No, units of blood were given over an hour and a half.
I mean, are they still going?
They haven't even come up from the blood bank
They're
yet.
still crossing the.
Oh, you haven't given it.
No, we're gonna
I'm
start
assuming
them.
you gave
No,
the
no,
blood.
no. The blood. We ordered the blood. Thank you very much. It's coming.
Okay.
By the way, blood infusion is not a volume challenge. You'll agree with that, right? So we're going to increase her oxygen carrying capacity because we think 22 is probably not that good for her. Actually, they think 22 is not good because they expect it was even going to go lower. So that's okay. When a surgeon says they think they should give them more blood post-operatively, there's usually a reason for it, even if they won't admit it. So I've been doing this for almost 40 years. So anyway, having said that, then, what do you think you'd like to do? I want to treat the renal hypoperfusion. Is this heart failure? I want to start dobutamine. Is this that they're bleeding and there's some coagulopathy? Well, I got an INR, there's normoplates. I don't have that. Start norepinephrine. Mean arterial pressure is okay where it is. I don't see a reason here. I could give them. I could just say, well, let's just see what happens if they start to pee on their own. You know, I wish rain were beer. You can't even do a whole lot of stuff, but if you want to see stuff happen, you have to fix it. And so the real answer is that you know that the pulse pressure variation is still 20%, so you'd give bolus, absolutely. And
First 2 units of FFP is more volume.
yes, but 2 units of FFP would equal 500 mLs, but it would be an awfully expensive way to do it, okay? Well, remember that hypovolemia is always relative. The clinical cues were persistent tachycardia despite a normal mean arterial pressure. What's your differential diagnosis of the tachycardia in her? Well, she just had this abdominal operation. She's starting to wake up. She could be in pain. You know, I can't not disagree with that. She could be anemic. However, I've got low urine output. And the low urine output's worrisome. However, in this sort of a case, where they did a transvaginal hysterectomy with bilateral salpingo-oophorectomy, I don't know if you remember your anatomy, but if you look at the ovaries and the fallopian tubes, they sit right over the ureters coming into the bladder, right? They're right in the same spot. So there is a real possibility in this person, if she doesn't respond, that you might have a structural reason for low urine output that has nothing to do with renal perfusion, but either they tied the ureters or cut them. You don't know. She could have acute renal injury, but it's kind of hard to buy that. You can't say that just yet. Okay? The helpful hints here are that the pulse pressure variation is greater than 15%, they're volume responsive, and remember our patient was 20. Okay. So assuming the patient remains tachycardic with a low urine output, if the pulse pressure variation is 35 and the CVP is now rising to 18 because it was 15 before, the next therapeutic intervention most likely to increase cardiac output and decrease heart rate is, same patient, to give dobutamine, start nitroprusside because you're worried about the pulmonary hypertension, which means you have to put a PA catheter in. Remember, she was a smoker. Repeat the volume challenge with Ringer's lactate or give Lasix because she's obviously volume overloaded. And I have seen every one of these given, by the way, for this situation. Okay. This is still hypovolemia, man. This person still needs volume. You gotta, I can't tell you the amount of times I don't see people fluid resuscitating patients. and they just wimpily go along and along and along. That's why you're there. You slam dunk what you need, get them stable, and then look. Don't go out, do it gently. Okay? You can give very small boluses. It's fine with me if you're worried about it, but do it fast and look. Okay? Well, this is just showing you the data on the stroke volume variation. This was a study we did in the OR with Andre Deneau, in which we had an automated bore detection algorithm on our ultrasound, so we could measure the area of the left ventricle. So this is the largest area, and it gets to smaller. So this is end diastolic area, stroke volume, stroke volume. And as you can see, with a positive pressure breath, the preload falls, and I get stroke volume variation. And this is the reason why pulse pressure variation is a good measure of volume responsiveness. This was a paper we published in Chest about, I guess, 15, 20 years ago. And then I showed you this study. In human beings, we put a flow probe on the aorta and put our finger on the inferior vena cava and measured the left ventricular stroke volume versus arterial pressure, and this is for one human being. And you can see as the stroke volume fell, the pulse pressure fell. So pulse pressure is determined by stroke volume on a beat-to-beat basis. So you can take pulse pressure variation to the bank. If a person is synchronized with a ventilator, it's going to tell you volume responsiveness, period. Okay? And you get it for free. And I showed you the LIDCO subscreen, where they actually, when we gave this patient PEEP, they became more preload responsive, but you can see here that the pulse pressure rose more in the stroke volume initially because there was immediately a more vasoconstriction that then vasodilated, but still, so you can actually dynamically follow changes in vasomotor tone as well. Okay, 3 hours following up. Patient now has gotten 4 liters of fluid by us. We kept giving volume after volume after volume, and it took us 4 liters. But she still, to eliminate the tachycardia. She started to pee a bit. Mean arterial pressure was 65 off pressors, never once saw norepi. The urine output is now up to 20 mLs an hour, so the surgeons were happy. The post-transfusion hematocrit was 28 after 2 units, but we'd given 4 liters of crystalloid. The CVP had increased and now gone up and down, but now it was at 15. A Foley catheter hydrostatic pressure, because the lady had a big belly. Remember, she'd had the intra-abdominal surgery, so we felt her belly. It was a little stiff, so I took the Foley catheter and I just hung it up like that, and I had a column of fluid in it. I waited for the column of fluid to equilibrate out, and I said, what was the height? Divided it by 1.36, and that's the number of millimeters of mercury that was there. It's that simple. You don't need a manometer. You don't need anything else. You got a column of urine. It works just fine. As long as it's connected to the bladder, that's your intra-abdominal pressure.
You have to wait, though.
Well, you have to wait a couple.
If the bladder's empty, you have to put something.
There is
in
no
it.
question
Reflux,
that the bladder's empty. That's why I never like to empty the Foley catheter. I like to have it having urine on it, so that when I pull it up, there's plenty of urine for this to happen on. But if some nerd has come in and emptied the whole thing out, then you have to put saline in or something to look at it, okay? But in general, it's not a problem. I just hold it right up. And I've been doing that, by the way, since I was a medical student, as a way of assessing intra-abdominal pressure. And it was amazing that there's actually a society now of intra-abdominal hypertension, because there's no society of intracranial hypertension, you know, and we think that's pretty important. So what we found was that her intra-abdominal pressure was 20 millimeters of mercury. Her arterial pulse pressure, by the way, had decreased now to 10% because we fluid resuscitated her. You with me so far? Good. Okay. The most likely cause of this decreased urine output in this patient is a marked increased vasomotor tone to sustain the mean arterial pressure, because she's now woken up enough that she's really clamping down on her own, despite the low cardiac output. Acute renal injury due to surgery, it was the surgeon's fault all along, and the transfusion causing the acute tubular necrosis because of all the myoglobin and stuff like that, and the prior hypotension. Obviously, people have poor urine output when they've had previous hypotension, or that there's decreased renal perfusion pressure, or none of these are the right answer. Which one is it? Decreased renal perfusion pressure, right. Because the venous pressure on the kidney is going to equal 20 millimeters of mercury. And if her mean arterial pressure is 65 and hers is 20, that means her mean arterial pressure as far as the kidney is concerned is 45. That ain't going to buy biscuits. It's not going to work. So this person if they're going to have any renal perfusion, you either have to decrease intra-abdominal pressure or increase mean arterial pressure, or they're not going to be perfusing their kidneys. Now, Cameron mentioned intracranial pressure. The reason why intracranial pressure rises when you give PEEP is twofold. Number one, the foramina of the vertebral bodies are in equilibrium with pleural pressure. So pleural pressure rises and squeezes on those. And that increases intracranial pressure directly. And you can prove that, and that was done many years ago by a guy named Fitzgerald, by simply an animal tying a knot around the cord and blocking it and showing that the PEEP had no effect. Okay. The other thing is that if CBP rises, it's going to be your intracranial pressure if it's higher than intracranial pressure anyway in terms of cerebral perfusion, right? So whichever one is higher, intra-abdominal pressure or CVP, intrathoracic pressure or CVP, will cause your intracranial pressure to go up, okay? So anyway, intra-abdominal hypertension compresses the vascular bed. You lose your volume responsiveness. Why do you lose your volume responsiveness? Because I'm squeezing in all my capacitance vessels. I basically have the equivalent of military anti-shock trousers, okay? I'm squeezing on the belly. Now watch this. If I've got intra-abdominal hypertension, and this guy over here, this joker over here splits her belly to fix it, and opens up the belly, what do you think is going to happen to her blood pressure? It's going to die, because you've taken away the pressure that's holding her vasculature, and belly's going to fill up appropriately with its normal amount of fluid, blood, capacitance, and you'll have no venous return. Okay? So there was further abdominal distension. The crick continued to fall, and we convinced the surgeons that they had to do an XLAF. And they agreed. And I told the anesthesiologist, before you go in, I want you to put in a second central line before you go in. And I want you to be prepared as soon as they open the abdomen to slam dunk about 2 liters of Ringer's lactate right into her as soon as possible, because she is going to become hypotensive. Well, upon opening the abdomen, the mean arterial pressure fell to 45 within a minute or less. Heart rate went up, her pulse pressure variation went to 45, and they gave her 2 liters of crystalloid. They didn't believe me, by the way, when we did this. They said, we don't expect that'll happen. Pinsky, what does he know? It was, like I said, this lady's gonna happen. Well, anyway, they found 3 liters of intra-abdominal junk, and they found that and blood, and there was a lacerated small valve that they'd missed from the and in fact it was bleeding. So they oversewed it. Oversewed it, washed it out, did all that good stuff, sewed her back up, put her back to the OR, and she was home 5 days later. Okay, interesting, huh? So the take-home messages. Okay, preload is not volume responsiveness. Okay, volume responsiveness estimates are good to predict cardiac output, but may not be effective as the only treatment. We can only do so much with fluid inotropes and pressors. Sometimes you need to go back to surgery. Sometimes you need to put in a stent. Okay, you can only do so much with cardiovascular monitoring. You're part of a team. Okay, intra-abdominal hypertension, when present, masks hypovolemia, so that because you're squeezing on the belly, the same way that the military anti-shock trousers, which squeezes on the belly, allows you to be alive even though you've bled. It's the same principle. It doesn't change it. Okay.